Well, welcome to Against the Wind, Doctors and Science Under Fire. It is an honor and a privilege to have Dr. H back in the house. We met in front of Salem not too long ago, and you are the Executive Community Director of Energetic Health Institute. You do a lot of teaching, education, and you're a real resource for COVID information, which is what I'm most interested in us diving into today, because you really get the data. And I think until we have real data to look at, we're just hearing sound bites, and that's not really helping anybody. So yeah, welcome back.
It's so good to be here, Dr. Paul. I really appreciate you having me on. And yeah, I hope in our work that we're educating enough people so we can get beyond the narrative and get beyond the sound bites. We got to start getting into conversations.
Yeah, absolutely. We're both here in Oregon. And of course, we just had our governor announce we're all going to be masking up everywhere indoors again. So here we go. And I know that's happening in other places. I think the driving narrative for that, and I'll have you maybe start there addressing this, is this Delta variant and the fact that it's being claimed that it's now the predominant variant. What are you finding in your data? And, is it more deadly? Is it truly the unvaxxed who are driving the current wave, as they seem to be announcing in the news?
Mm-hmm. Well, there's a lot of fiction that's being pushed in the news that I think we're all finally starting to hone in on. So let me share some stuff, because one of the things that's, I think, really important to me is that we always share information that we can substantiate. And I think it's very important that we always share information in the hopes of collaborating with the governor's office, with the Oregon Health Authority. It's something that I'm still working very hard to do. I just reached out to Dr. Dean Seidlinger last week in another effort to try to collaborate so that we can get nutritional guidance issued to help slow and increase the preventative measures that we haven't really taken, I think, with any level of seriousness. And I think we're starting to see the folly of that kind of approach, so just so we can have it on record so everybody can hear, I'm not a rabble rouser or anything. I really want to educate, and I really want to collaborate. And I think that's the energy that's going to get us through this crisis in a good way. And I think it's what we have to focus in on. I also think that when people are doing a poor job at something, that they should have the integrity to resign and let new ideas come in. So but that's just my own personal point of view on that. So let's take a look at a couple of things right now. I want to start with the Delta variant. So this is something that your audience can go and verify. This is the CDC's COVID data tracker. This is specifically for their variant proportions. And I want to show the audience how we get to these scary number percentages. So first and foremost, the Delta variant is also known as the B1617 lineage, and now there's three sublineages, 1, 2, and 3 as well. And I think when you put all of these percentages together, as you can see, if you were to go with this, they're saying in the USA that roughly 94% of all cases are now associated with the Delta variant, which can be very, very scary. So let's show everybody how we get to these numbers, how the CDC gets to these numbers. So the first thing that happens is that states that are participating in genetic sequencing, so states can send samples in to the CDC for specific genetic sequencing so that you can know whether or not it's Delta variant or not. I think it's very important for the audience to know that the current PCR tests cannot distinguish different variants. It's just kind of, is it there or not? And then we have that whole cycle threshold issue of, are you above 28 on the cycle threshold? And if so, is it a false positive? And that's something that still hasn't been corrected, even though that issue has been raised for over a year now. And I think that's not okay. I think that really handcuffs our frontline healthcare workers, and it puts them in a really bad position. So when we look at this, these are the states currently that are participating in the CDC's genomic sequencing, so we can know what variants or what estimated percentages are. So the first thing that I want to show everybody here in Oregon is that Oregon is not participating right now in this. And that's a very big concern for me. 2 weeks ago, Oregon was participating, and Oregon, the OHA, had submitted enough samples for the CDC to sequence. And at the peak, the last time I had checked, On record, it was 11.5% of all samples submitted were Delta variant. Okay, so
And that was just 2 weeks ago.
2 weeks ago. And the week before that, it was 2.6%. So it did go up, but one of the things that we've seen the OHA and the Oregon Department of Education recently claim is that 80% of all new cases in the state of Oregon are associated with the Delta variant. Well, you can't make that claim if you're not participating in genetic sequencing. And so what's required for a state to participate in this? Number one, they have to submit at least 300 samples over a 4-week period. So it's a very small number, okay? And you can see the states that are participating in this. You can see that all of these samples that they've submitted in are there's roughly about 20,000 samples over a 4-week period that the CDC has sequenced. Now, what I want the audience to understand is that's 20,000 samples that they've sequenced out of a possible 850,000 to 1 million. So you're talking about really taking less than 1% of possible samples that you could sequence, and then extrapolating from that what your estimated percentages are. So the first thing is that when you take all these, you want to acknowledge that not every state is participating. So it makes it very hard to say this is what's happening all over the United States. This is a lot of guesstimate work, and we shouldn't be guessing when we can know, in my opinion. It's one of the things I teach all my students. Don't guess when you can know. And I don't know why we're not being more adamant about larger sample sizes here and every state participating so we can really know. But that's just what I see. Now, the next thing that the audience needs to know is this is the unweighted proportion. So these are just, here's the number of samples we took in, we sequenced them, and this is the percentage, right? This is just factual kind of data here. Well, the CDC then does something else once they get to this unweighted proportion. They then will, let's see where they move this information. This information moves around. Here we go. Then what they will do is do statistical weighting on it. So they'll take the unweighted percentages and add a fudge factor on it so that they can estimate and kind of say, okay, in the worst case scenario, it's this percentage. And that's why you'll see these ranges in there. Then they take the weighted percentages and they spool them up a little bit more into projections. And this is one of the things I've been railing against for the last year is we have to stop using projection models because projection models are so often wrong and easily manipulable. So if we take off the projection model, if we take Nowcast off right here, this is funded, of course, by good old Microsoft. If we take off Nowcast, let's just give it a second here. What we're going to see is just the weighted percentages. So what you see right here is that knocks down the Delta variant by 9% right there, right off the bat. Okay. Now, if we take that and if we take off the weighted percentage, of course, they don't tell you how they're weighting it. So you don't know how significant it is. I'd have to do some more calculations to go in. But the reality is this, we have only a select number of states participating. There's just a minimum 300 they have to submit over 4 weeks. So there's no reason why every state shouldn't be involved in this. Oregon isn't involved in this right now. And what we're seeing is once they get these numbers, these percentages, they then weight them and then project based upon the weighted estimate. And what that does is it is the difference between reporting in the media 71.3% for the Delta variant, or if you wanted to add the A13, the AY3 lineage in there, 84%, right? It's a difference between telling and saying in the media 84% of all new cases are Delta variant, or if we go to the projection model, the projection model spools that up even higher now to a really scary number, which is what? Dun, 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 dun. Let's see when it comes and it's thinking. Come on, baby, you can think.
While it's thinking, let me ask you a question you can ponder on as well. I'm hearing and learning and reading that the Delta variant is more contagious, but less dangerous. And I'd love your comment about that.
Sure, and I'll share some clinical, because that's something I'm going to be investigating this weekend a little bit more. I got to get back into the state level data. The state data that I was looking at last year for this was much more accurate than the CDC data. So I'm going to go back this weekend and spend some time looking at every single state health department to see where we have similarities between what the states are saying, what the CDC is saying, and where we have differences of that, because that's where it's in that chaos where you can say anything you want and it's technically not untrue, you know. So we'll take a look at that, but I'll give you some anecdotal stuff in a second. So if we don't project, it's roughly 84%, right? But if we project and add even more fudge factors into this, it creates now a 94%. So it basically, they've gone from the weighted amount, the unweighted amount, which is based on about 1%, maybe 2% at most of available samples. And they're saying that this 2% that we're testing is indicative of everybody in the entire country. So that's obviously a very dangerous thing to say, right? Then what they do is they say, well, let's fudge factor that and take it up a little bit more. Then let's say that that's for the entire USA, and even though we know not every state is participating in this. And then let's take that fudge factor that we've brought up, and then let's project what it is and take it up even higher. And now we get our scary number for Americans, that 94% of all new cases are Delta variant, and we should all be freaked out. Well, that's a really incredible thing to say, especially without the empirical evidence to support it. Projection models are not empirical evidence. They are guesstimates, and I think we have to hold them accountable to that. So that's concerning. Now, as far as the Delta variant goes, you know, let me say first and foremost that this is just anecdotal evidence on this. I've talked to some colleagues who run urgent care centers, and they've said that they are starting to see, and these are in major metropolitan areas, so they're starting to see cases rise up again. They had one of my friends had told me that a couple weeks ago he sees about 100 patients a day. He said he was seeing 0 COVID cases. And then a couple weeks ago, it started going up, and he said right now out of 100 cases, he's seeing 10 to 15 COVID cases a day. Okay, yeah. So 10 to 15% of what's coming in. So then I asked him how many of those people are being hospitalized and having to be sent to the hospital. He says he typically has to send about, 2 or 3 people to the hospital every week. But what he did say, and he's a good dude, is that they're all unvaccinated. And that's something that I need to look into more, because he's saying the people who are having the more severe respiratory pneumonia issues are unvaccinated. And I think that's something we need to be aware of, rather than saying, well, I don't believe it. I want to investigate that a little bit more.
Because I certainly have seen reports from other parts of the world that have the exact opposite. Most of the hospitalized are vaccinated.
Right. We've seen that. We've seen, Dr. Paul, in Iceland, Gibraltar, Israel, and the
Australia.
United Kingdom, and Australia and the United Kingdom. So it's hard for me to say right now, and I don't want to make a statement other than to say this is why it's anecdotal. This is what I'm hearing. Now, what I'm also hearing is that and we just saw the CDC confirm this, is that CDC on August 6th just published this report, Outbreak, and you can see it CDC, Outbreak of SARS-CoV-2 infection, including large COVID-19 vaccine breakthrough infections associated with large public gatherings, right? And this was out of Barnstable County, Massachusetts. So let me read this for everybody right here, because this was very telling, this portion of it for me. Because, the narrative became very quickly, well, this is the fault of the people who are saying, I am going to hold off on getting vaccinated. And I've talked to a lot of people who are saying, you know what, I just want to wait until the clinical trials are done. The clinical trials are not going to be done until late 2022, early 2023. I want to wait. I want to see the data, because I don't want to just rush in to this, because they've seen too many cases of the myocarditis, the pericarditis, the heart attacks, and so forth, right? And it's like, if you're in a age range and if you're healthy to begin with and you're in an age range where there's a low risk of serious side effects, serious complications, death, long haul syndrome, then it makes sense for a person to say, hey, I just want to wait. I think that's being very reasonable for people. But the coercion and the pressure is not acceptable, not for an experimental. It's not ethical in my opinion.
Yeah, agreed.
Now, so what they're saying here, the CDC is saying in this study, and you can see there's a lot of people on this study, right? A lot of PhDs on this study. During July 2021, 469 cases of COVID-19 associated with multiple summer events and large public gatherings in a town in Barnstable County, Massachusetts, were identified among the Mass residents. Vaccination coverage among eligible Massachusetts residents was 69%. So their stated goal is 70%, right, for an area. So that's right there. Approximately, this is where it gets interesting, Dr. Paul. Approximately 3/4, 74% of cases occurred in fully vaccinated persons.
Yep.
Okay. So this is saying you are more likely to have a breakthrough infection if you are vaccinated. As opposed to not. Okay. Yep. And that's a concern. I think it's really concerning for me as well that we're not tracking effectively, at least the CDC isn't publishing this data. If they are tracking it, how many of these people, how many of the cases are. Now we know at states they're tracking breakthrough quote unquote cases, but the CDC is only tracking breakthrough hospitalizations and breakthrough fatalities. And they have a different set of rules, which I think is unethical as well for tracking them.
Right.
The cycle threshold for a person who's just out in general population is 40 cycle threshold or less means you're positive. But if you've been inoculated, it's 28 or less.
Right. It's just ridiculous. You're comparing apples and oranges. It's interesting that this particular study from Barnstable County, Massachusetts, where 74% were fully vaccinated, the rest of them, so the other 26%, included people who had had one vaccine, included people who had had both vaccines, but it hadn't been 2 weeks yet since their second vaccine, and it included people whose vaccine status was unknown. So the data is actually much more significant than even presented here.
Exactly. They're doing everything they can to manipulate the data to keep the narrative that these are safe and effective.
Yeah. So how about, I know you've, sorry, I interrupted you there.
No, you're good. You're good.
Take us on that risk benefit analysis. I know you've done a fairly deep dive into looking at the, let's really look at the risks versus the benefits of getting a vaccine, because I mean, that's really the decision that people have to make. These are experimental vaccines still. We don't have completion of the trials. And so what data do we have that we can really dive in and analyze the risk and the benefit? So I'm really eager to see what you've done here.
Well, what we did in the beginning of July and July 9th was we looked at CDC only data. I don't want any noise. I just want to say, what is the CDC saying about this? So we went to their COVID data tracker and we looked at all of the information for the infection. Okay, so this is where you see how many cases by age range, how many cases, how many deaths in that age range, how many people recovered in that age range based upon the CDC criteria for recovery, which means what you do is you take the people who are supposedly the total number of cases, you subtract out anyone in that age range who has died, obviously. You subtract out anyone who is hospitalized currently, and you also subtract out anyone who is positive within the last 10 days. So we remove all of those people, and that gives us how many estimated recoveries we have right here. And as you can see, everything is properly cited in here for anybody who wants to take a really close look at this. And what that does is it allows us to establish what the recovery rate is in these age ranges. So for example, in the 0 to 4 age range, the estimated recovery rate is 99.972%, which, as you know, is better than the seasonal flu. And we see that when we put all this together, even in the 50 to 64 age range, which is right at that high risk, now we're starting to enter into that potential high risk, especially if there's underlying conditions. These folks are still recovering at a 98.628%. So when now we say, okay, well, let's aggregate all of these together from 0 to 64. What's the estimated recovery rate? The estimated recovery rate is 99.577%. This is not an emergency. There's no way to justify this as being an emergency. Now, what it also allows us to do is it allows us to establish a very rudimentary way of understanding gain of benefit. And that is, if I were to take this experimental therapy, what is the potential maximum gain that I could get from taking it? What's the closest to 100% guaranteed recovery I could get? So in these age ranges, look at this, 0.028% potential gain of benefit. There's no potential gain of benefit in that age range. Now, in the 5 to 17 age range, look at the potential gain of benefit. It's even less than the young infants and toddlers. It's 0.011%. There's no gain of benefit here. And then when you get up to the 50 and 64, it's 1.372% gain of benefit. We don't start seeing substantial gain of benefit until you get to 65 to 74 and 75 and older. That's where you start seeing significant gain of benefit. But what's our normal life expectancy? 77.5, I think 54 or something like that as of 2018. So what we're showing here is that where you see green, there really isn't a substantial gain of benefit, but where you see red, you could make an argument statistically that there is potential gain of benefit here, right? So we want to be very fair, and I just want to look objectively at data. Now, we went over and we looked at the CDC COVID data tracker, which also has the number of people inoculated by age range. So we put all that data in here, and you can see it by age range. One of my big fingernails on the chalkboard, Dr. Paul, is when the same agency doesn't use the same age ranges to track the same stuff. This is the easiest thing to do, is just compare apples to apples. So there is going to be a little bit, as you can see here, age under 6 and 6 to 17 versus 5 to 17. So I just want to acknowledge that, that I'm using the data that I'm presented with. I'm not manipulating the age ranges to try and make the outcome different. I'm using the exact age ranges that the CDC is presenting. So what we see here is we have the number of people inoculated. Okay, now in the age 6 to 17, of course, this should be people 12 and older, right? Our kids 12 and older. I am beside myself that 195,000 kids under the age 6 have somehow gotten inoculated, and that the CDC isn't in an uproar over this, taking any practitioner's license who has done this, right? But you don't hear anything about this, do you? Nothing about this, but the CDC is actively reporting that this is happening and doing nothing about it. I think that's just completely unethical and unconscionable in this situation. So then we went over and we looked at the CDC's Vaccine Adverse Events Reporting System, CDC Wonder, and we looked at injuries and we looked at deaths in these age ranges, okay, associated with the COVID vaccine. Of course, we can't say causation, but what I will tell your audience is, as of last Friday's report, a little over 4,500 Americans had died within 48 hours of receiving the inoculation. So for me, objectively, that starts to enter into the discussion of causation. Okay, so I don't want to hear people telling me that there's no causation. Just because you say it doesn't make it so. Okay.
Yeah.
So what we look at here is we look at injuries and deaths, and we look at predominantly risk of injury. And so that gives us a percentage of the people who have been inoculated, how many of them reported an injury. So that starts showing us what the potential risk of injury is in these age ranges. Now what we do is we compare the potential gain of benefit against the risk of injury. And what we found was that in the under 6 age range, it's a 3.4 times greater risk of injury than benefit. In the 6 to 17, it's a 15.6 times greater risk of injury than benefit. In the 18 to 39 age range, it's 3.2 times greater risk of injury than benefit. And in the 40 to 49 age range, it's equivocal. It's almost equal. So you can't make an argument that the benefit exceeds the risk. So That's where you see red here. I'm saying based upon the data, and this isn't me, I'm just showing data, right?
Yep.
It doesn't seem like the experimental inoculation should be approved for anyone under 50 years of age. If somebody wanted to say, 40, 49, since it's equivocal, it should be approved, I wouldn't argue with them, but it's very difficult to make an argument, especially anybody under 40 should have access to this. Now,
So what's your explanation? This is like the data speaks so loud, and
right.
yet that's not what we're hearing from our public health officials.
I honestly think what we have to do is we have to change gears. We have to follow the money. When you start looking at Pfizer's updated annual report, it went from 25 billion to 33.4 billion or something like that for this year. You have to look at the contracts that have been leaked now from these companies, Pfizer, Moderna, and everything. You have to look at, my opinion, at conflict of interest. The NIH should not be able to be involved financially with Moderna. You have to look at conflict of interest. I'm still appalled. I dropped my jaw this week, and I had to go to Forbes to confirm this, Dr. Paul. Tony Fauci is our highest paid official, elected or appointed in the United States government. And I find that just jaw-dropping, that somebody like that can be appointed and make more money than the person who appointed him. We have some fundamental things going wrong. I just interviewed Dr. Sin-Heng Lee on my radio show. That interview will air on Saturday on the America Out Loud platform. I just interviewed him, and he dropped my jaw again, pointing out that the CDC owns patent rights to the PCR tests. And so they're making royalties on all of this. And then people go, okay, well, so what? And I'm like, well, wait a minute. Who's paying for all this PCR testing going all around the country? Well, the government is. No, the government isn't paying for it. The American taxpayer is paying for it.
Absolutely.
This is siphoning. You're siphoning American taxpayer dollars into a different organization for a test that we know to be fatally flawed and not able to distinguish who's infectious from who's not. We are doing everything we can to seemingly create chaos and hamstring our frontline healthcare workers, and people are profiting off of this. This is wrong.
Yeah. And for the longest time, that was the only test allowed.
Exactly. For me, I think, I was really struggling the last 2 weeks over this, because you start reading, you start getting into the data and going, well, wait a minute, this is not anything that they're saying on the news. And, and people are getting scared and freaked out all over again. And I understand that. I mean,
if you watch the news, the sky is falling.
The sky is falling, right? And if you watch the news, and I think what I had to finally reconcile, I think we need to simplify our messaging. I mean, this is very deep data dive. Hopefully I'm explaining it well to people, but I think what we also have to do is just get into a simple discussion of ethics, of right and wrong.
On that point of simplifying this data that's sitting in front of us, tell our viewers who are 50 and under what this says in a simple sentence.
What this says is that at best, the risk of injury equals the risk of the gain of benefit. And that's not what you have to prove in medicine, especially with an experimental product, is that the benefit exceeds the risk.
And under age 40?
Under age 40, it's by factor of 3.2 up to 15.6 times greater risk of injury than benefit. And I need to be fair here, because you're under a lot of heat. I got a lot of heat on the horizon. I want people to understand I'm not coming at this from number one, I'm not telling anyone what to do. And I want to be really clear with that. I will under no circumstances tell anyone to do. I just talked to my whole team that I don't care if you are inoculated, I don't care if you decline it, you will have a job here. We will not participate in any forced mandates. And I don't care if that means they want to fine us. I will not allow a government to dictate what goes into any of my employees' bodies, or force me to dictate what goes into any of my employees' bodies.
Thank you. I share that same sentiment. My employees all know that they are free to be vaccinated. They are free to work here if they're not, because we have this conflicting data and this powerful data that you've just presented that really empowers those who choose not to be vaccinated, especially if they're younger or low risk, that's a sensible, data-based, science-driven decision.
Empirical evidence. We have to use empirical evidence, and especially empirical evidence that we can trust, right? And we're supposed to be able to trust the CDC data, right? We have to use empirical evidence that we can trust to guide decisions. That's why we have data, not to justify narratives, but to guide decision-making and policy development. That's it. The data is supposed to lead that, not be manipulated and trail it. And that's what's been happening. So
absolutely. Maybe as we close, you can take us to your data on the sort of death audits.
Sure.
Took a look. I mean, I've known because of the problems with PCR testing and the massive number of false positives that were created by having cycle counts of 35 and above, which most of the testing was at that level, we created an epidemic of positive tests.
Right.
And even the deaths, if many of those deaths were false positives, it's a false attribution of what caused death. So I'm very interested in your analysis of the audit of the death counts.
Amen. And let me, before I go off of this one, let me just say, just to be fair, and with that we're on record, both you and I, Dr. Paul, see that in the blue areas, 50, 64, 65, 79, and 79 plus, the data says that the potential gain of benefit exceeds the risk. So you can see we're being objective. We're not slamming something, and I'm certainly wouldn't want to take something like that away, that option away from people in those age ranges that we're seeking it. So looking at that, let me bring this up, Dr. Paul, and I'll tell you a little bit. I got contacted by a high-ranking elected official asking me how they can get a hold on the cycle thresholds. And I said, well, you're an elected official, you should know better than me. But I said, well, why don't you just do a records request from the state health department that you're in? And he said, okay, I'll do it. Will you help me write? I said, sure. I don't want to be leading or anything, but if you write something, I will help shape it, and I'll put it out to some of the other scientists that I collaborate with, and make sure that we're wording it the right way so that you can get what you're asking for. So we did that, gave him back to him, and he submitted it. And the state health department denied his request. He was simply asking for the positive cases with a cycle threshold greater than 35, I think, or 32. He just wanted to know that number. After reading all the information about cycle threshold, and was denied by an elected official, high-ranking elected official, was denied access to records that should have been public from the start.
Absolutely. If we knew what the cycle thresholds were for all the tests that were being done, even a reasonably intelligent person, and certainly clinicians, would know the meaning of it. In my own office, I had a machine initially that they would not tell me the cycle threshold, so I swapped it out for a new one. And when I finally got information of what the cycle threshold was on the new machine, it was 40 cycles. So it's like, I'm doing these tests because daycares need them, and schools need them, and camps need them, and people's places of employment need them. But I'm going to get a lot of false positives.
Right. And you know what? If they use the same 40 or lower cycle threshold for breakthrough cases and evaluation, I wouldn't like it because I still don't think it's accurate, but at least now you're getting to compare apples and apples, right?
Right.
But if you can't have one set at 40 and the other one set, you can't have the one that you want to hyperinflate cases set at 40 for false positives, and then the one that you want to de-emphasize vaccine breakthrough, otherwise known as vaccine failure, as at 28, because anything over 28 is likely a false positive. That's just it's unethical.
And for our viewers, this actually happened. The CDC made a mandate that you could not report a vaccinated person as positive unless they were using a PCR of 28 or less. And I think that was back in May, wasn't it?
Yeah, it was actually right before May. It was when they decided to stop tracking cases and they just moved to hospitalizations, fatalities. You can verify that at the CDC, and you can go to their breakthrough cases right here, and you can go down. They hid it. It used to be out for everybody to see, but you can see here's their breakthrough cases. But you got to scroll all the way down to the bottom, and then you got to expand this accordion here so that you can see that what we're saying is valid. It's right here. Excuse me, right here, and you can see what they're saying. For cases with a known RT-PCR cycle threshold value, submit only specimens with a cycle threshold, that's what CT stands for, value lower than or equal to 28. They're telling you point blank, we will not accept anything for counting higher than 28 cycle threshold.
Yeah. So that basically, folks, eliminates the vaccinated from being counted when they get sick with COVID.
Mm-hmm.
And so then when they report in the news that it's mostly the unvaccinated, well, right there, you know why.
Right. Exactly. You're cooking the books. I mean, if we can just break it down for folks, you're cooking the books, and that's exactly, we have laws in our country, and this is what we wrote a peer-reviewed paper on last October, Dr. Paul, on the Information Quality Act, the Administrative Procedures Act, and the Paperwork Reduction Act, all of which ensure that no federal agency and no state agency as a byproduct should be able to do that. That we are supposed to have oversight over all this to ensure that never happens. Well, let me take everybody through this. And this is, again, February 21st through July 9th, 2021. So February 21st, 2020 through July 9th, 2021. You can see where the references are for the data on this table. This is where we're going to compare COVID death counts. Now, on March 24th of 2020, the CDC did something very interesting. They completely changed how death certificates are recorded, but only for COVID-19, and without going through due process by announcing that they wanted to change this, in the Federal Register so that you could initiate oversight and public comment. These two things never happened. They just changed the way death certificates were going to be reported. And the major change that they did, Dr. Paul, was they said, normally we would put comorbidities, underlying conditions in part 1 of the death certificate. And that's where we usually get most of our statistical counting. And what they said was, now put those comorbidities in part 2. So it looks like those aren't causes of death. And what you can put in part 1 now is COVID-19 all by its lonesome, so it counts up. And that's where people have heard that a person got hit on a motorcycle, a person got shot, a person, was working out in their backyard and fell off a ladder. And all of these deaths could be counted as COVID because the minimum medical measurement for whether or not a person was COVID positive, and this is according to the CDC on a April 14th document, was a single cough. All you had to do was have a single cough, and then a doctor could legally put COVID on your diagnosis. And if you died, that's what could go on your death certificate. That's how you inflate death certificates. That's data manipulation. And that's exactly what's not supposed, that's exactly what is illegal according to our federal laws.
Well, and to make it more likely that would happen, they also incentivized hospitals by paying them massive amounts of money if it was a COVID death compared to if it was not a COVID death.
20% bump. If it was a Medicare, Medicaid, it was a 20% bump, which Dr. Scott Jensen, the senator from Minnesota, showed amounted to an average of $39,000 greater return on claim per person. So you think a hospital's no hospital administrator is going to care about if somebody did what the diagnosis was. Give me the diagnosis that's going to give us the biggest return on it, right? That's how it works.
Absolutely. So
what we get there is we get incentivized complicity, right? And what we get is an inflation of death certificates. Now, what we see is there's 494,807 deaths as of July 9th. For COVID, and that's using these changes that the CDC made on the 24th of March. What I've found very fascinating, and this really shocked me on January 1st, was every January 1st, we reset the board on everything, right? But COVID never has had its board reset. We just keep adding more. So we can't even compare 2020 to 2021, right? And it's just like these little subtle things. So a couple of weeks ago, Santa Clara County, California, which houses San Jose, the city, and Alameda, California, which houses Oakland and surrounding areas, so sizable populations, did a soft audit of their death certificates, their COVID death certificates. Soft audit means we're just going to remove the things that we obviously know should have never been listed as COVID. That reduced their death certificates by 22 and 25% just off the top. Okay. So if we were to apply a 25% reduction on a soft audit, that lowers this to 346,000 deaths that are, so we're not in an emergency state at that point, because you're talking about 17 months worth of data, 346,000 people, and it's sad. I'm not saying it's not sad, but what I'm saying is we got to get to data accuracy if we're going to make good decisions and get through this. Now, our information in the peer-reviewed paper that we published, and if the CDC hadn't violated federal laws to manipulate the death certificate reporting, if they had just used what we use for everything else, and we've been using for everything else since 2003, the real count looks something like this: 29,688. Now, are we saying that this is the actual count? I'm going to be very clear about this. No. What we are saying is that it could be as low as 29,688, which obviously is not an emergency situation under any stretch of the imagination.
Yeah, that would be more in line with a typical flu season.
A typical flu season, maybe even less, right?
Right.
Than a typical flu season.
Yeah, certainly less than the bad ones.
Now, when we look at this, what's really, really important is that what we're advocating for is not saying, hey, we're right. I know No, what we're saying is we need to analyze every single death certificate and correct this count. We need a full audit of all death certificates to correct this count, because this is wrong. I can say with 100% certainty, this count is wrong. Now, when we compare what it could be, as low as 29,000, to what we know minimally it is in terms of death resultant, or death in connection with the experimental vaccine. What we're seeing here is that they're almost on par here, and because this is over 17 months, this is over 8 months. And then if you take into account the sworn affidavit that the whistleblower Tom Renz found and filed in U.S. District Court on July 19th or something like that. That whistleblower had access to the CMS database and cross-referenced it with the Vaccine Adverse Events Reporting System database. And what they found was that there is at least a five times a factor of underreporting, meaning that this number here reported to Veris is likely 5 times greater than what's currently being reported. And if that is true, what that means, and if this is true and we audit and we found this to be true, what this means is that we very well could see more people have died in connection with the experimental inoculation than died from the actual infection.
Yeah. And as we move into Delta virus, which is less deadly, it would appear those numbers get even worse.
It gets even worse, especially when you take into account the one thing we can definitively say about the Delta variant is that the vaccine failure rate is through the roof with respect to the Delta variant. I think I read one report yesterday that showed that Pfizer's relative risk reduction that they said was 95% to get this whole sold is now down to 39% in Israel and 42% in the United States, which means that you're basically flipping a coin whether or not it's going to work. And that's not enough for an experimental product.
No, not at all. Well, you've given us a lot to chew on today.
Sorry.
It's really important stuff. I wanted our audience to be able to get this information. So, you know, when you're feeling pressured, whether it be by your employer or by friends, family, to come on, be a team player, take this vaccine. Well, there's a subgroup, certainly the 40 and under, there's no question. It appears that is a very poor choice. I mean, if you're going to just use the data and the information present. And we still have no long-term safety studies for any age group. So we're entering a uncharted territory once again. Thank you for bringing us this information. Do you have any parting thoughts for our audience?
Yeah, I do. This comes back to it's gotten so chaotic. We have to make sure we bring it back to simplicity. And the simplicity is right and wrong. The simplicity is empirical evidence guiding our decision making. And the simplicity is reminding ourselves that we get to decide whether or not we want to do it. And if so, I support you. Or if we don't, and if you decide against, I support you. It's that we have basic freedoms that are protected by our Constitution that were given to us by brave men and women who sacrificed everything so that we could have these discussions. And it's important for us to honor them by exercising our freedom, whichever direction that is. I support you. But one thing I will never support is going to be any mandates. One thing I will never support is going to be any passport concept, whether they call it that or not. You as an American have a right to decide, you have a right to agree to it, and you have a right to refuse. And the direction that I'm seeing us going right now, I'm a historian, is eerily reminiscent of pre-World War II Germany. Yeah. And I just cannot sanction any direction, any movement in that direction. I'm very concerned about the direction of our country. I'm very concerned for our children. And so if you ever want to know why I'm doing all this, it's because I believe it's our duty to make sure our children and the generations that come after them maintain the freedoms that we were born into.
Yeah,
so that's simple.
Amen, brother. That is really, really important. And I'm going to end with how you sign off. The greatest energy always prevails. Love and kindness are our greatest energy. So that is awesome. And you've given us a lot of love here, taking, actually, I know, because I'm under the gun with the Oregon Medical Board, that it takes a lot of courage to just speak the truth, even though you're just reporting what you're reading from the CDC. You're choosing to share the information that they're trying not to share and that they don't want shared. And that takes a lot of courage. So thank you for doing that. And thank you for being on the show.
Thank you so much, Dr. Paul. It's always an honor to be here.